Hey, welcome to KRAS Kickers. This is Terri Conneran, and I am a KRAS Kicker and founder of the organization. Today, I am excited to welcome you to our event called BAM Cancer Biomarker Awareness Moments. And it's a privilege, truly, to have with us Beth Sandy. She's a nurse practitioner at the University of Pennsylvania. She's a nurse practitioner there, thoracic oncology in Abramson Cancer Center, University of Penn, Philly, and she's been in this role no matter how young she really looks. She's published a number of peer-reviewed journals and speaks regularly at conferences annually about the care for lung cancer patients. And although she is in thoracic, and we do recognize that a lot of the folks in here are going to be listening as it pertains to outside of lung cancer. So outside of lung cancer, there are biomarkers and there are oncogenes. I'd like to make sure to give a big thank you to the people and companies that allow us to keep the wheels on the road and do this for everybody. Amgen is one of our sponsors, AstraZeneca, Mirati Therapeutics, and Revolution Meds. Thank you all to everything that you do and for KRAS Kickers great. Welcome to us today. Beth, please, last shout out before I forget. If you are in the witness protection program, if you just don't want to be on video, please shut off your video. This is being recorded. We will be putting it later on the website. We do have a YouTube channel. So this is being recorded. So also please feel free to make sure that you're muted, because there's nothing worse than hearing somebody else's. Okay, welcome back.
Thank you so much, Terri, and thank you for everyone for having me. I am just going to share my screen here a minute. Oh, there's the curtains we were looking at, Terri.
Oh, okay, cool.
Because of the blinding sun in my window right now.
We just thought it was a halo that was headed your way.
Yeah, so as Terri said, I am a lung cancer nurse practitioner at the University of Pennsylvania. So I will apologize now because a lot of these slides are lung cancer specific, because that's all I know. That's what I've been doing for the past 20 years. And I am a nurse practitioner, so I'm not a pathologist or specifically a molecular pathologist. So some of this is coming more from a nurse practitioner standpoint. But biomarkers are sort of my life, looking for these and looking at reports. So hopefully I can help you get out of this, something to understand about what we're actually looking at here. There are some high level areas to this. I'm not even sure I understand it completely. So I want you to be aware, like, even when I'm showing you some of the high level stuff, I'm just trying to explain what you're seeing on the report. Okay. So that's where I work over there on the right-hand side. Let's start off by how do we perform biomarker testing in non-small cell lung cancer? And again, this isn't all cancer, so I'm sorry. Some of these slides are copied and pasted from my other talks. So in all cancers, really. But some of this again.
Hey, hang on one second. Let me make sure, because they're saying that they're not seeing your slides. Okay. You're just seeing just the speaker. Okay, so let me see. Did I do something wrong?
Do you see them?
I do not, but sometimes I've got two screens, and so sometimes it's like on some screen that's mysteriously in the background.
Does anyone else see them?
No.
I can see the slides, Terri.
You can? Okay.
Yes.
Marine's shaking her head no. She's the only person I can see on my screen. So let me see if I do this. Let's try that. Does that help? No. Okay. Share screen. Let's stop sharing your screen, and I'm going to come back again.
Okay.
Okay. And then
share.
Okay, and then let me. Okay, let's just.
I think they're saying they can see it now, Terri.
You can see it now? Okay. It's gone again.
Well,
Okay.
now I stopped sharing, so.
Okay, now share it again. Something was hung up. I think I've identified, I can see it. Can you guys see it? Yeah,
Yes.
okay, fantastic, perfect. All right, sorry, please continue.
Yep. So how are we performing biomarker testing? I'm just going to go through some of the techniques. I think you probably had a little bit of this in your previous talk, but I just want to lead in by again reviewing, because this is some of the nomenclature that you're going to see on the sample reports that I'm going to show you. So immunohistochemistry is the first one. So immunohistochemistry is what I always say, a quick and easy. So this is a stain. So if they are putting a slide under a microscope, they can stain cells and just kind of get some information from that. This is not a DNA technique or DNA extraction technique. So a lot of times we're using things like in lung cancer, we'll see if a certain stain is positive, such as TGF1, that will say, okay, that means if it's staining positive for that, it's a lung cancer usually. The challenges, though, of immunohistochemistry are that it's a low sensitivity for really actionable biomarkers. So sometimes an immunohistochemistry stain will say, oh, I see something like ALK or ROS1, but that doesn't always mean that it's actually there as a true biomarker mutation. So this is really best to determine kind of simple proteins that you're looking for. It also can show PD-L1. So I don't know if any of you have talked about that, but PD-L1 expression is something that can look at what the percentage of expression is on the extracellular domain of PD-L1. And that can predict for you in some types of cancer to respond better to immunotherapy. But honestly, it's not the end all be all of a biomarker, because for example, in lung cancer, even if you're completely negative, we still give immunotherapy. So it's a predictor, but not necessarily prognostic of how you're going to do. But IHC can detect PD-L1, but it cannot detect our more specific biomarkers, and it cannot certainly detect KRAS. Okay, so let's go on to the next technique, which is FISH. So FISH is something that we've seen used a lot in breast cancer. So this is a little bit more of a sensitive test. It really requires specific equipment, and the people who are reading it need to be specifically trained for FISH testing. So it's more sensitive than immunohistochemistry, but less sensitive for a next-gen sequencing panel. Again, it can detect some of our gene rearrangements or our fusions, such as ALK and ROS1 in lung cancer. It detects HER2 expression in breast cancer. And that's where we primarily are using FISH for HER2 expression in breast cancer. But again, even though it can detect some of these lung cancer ones, it's not as specific as a true next generation sequencing panel, which is the DNA extraction panel, which is what I'll show you next. So these are in order of sensitivity. So IHC, the least sensitive, FISH, getting a little more sensitive. And here are the last two. These are by far the most sensitive. So NGS is a next generation sequencing panel. There are several companies that have their own platforms. I usually don't name them because I don't want to be biased, but they're like at University of Penn where I work, we have our own assay that we use for next generation sequencing. A lot of large academic health systems will have their own, and then there are companies across the United States that have their own assays as well. This is the most sensitive test. This can detect everything, your fusions, your point mutations, your insertions, your deletions. KRAS is a point mutation, so this is where KRAS would be found. The downside or challenges of this is it takes 2 to 4 weeks. And at my institution, that's more like 4 weeks right now. So that's really the frustration. This takes a long time for us to get these reports back. It requires a lot of cellularity in the specimen. So in my world, in lung cancer, we have about 20 to 30% come back as QNS, which means the quality or the quantity is not sufficient. There's not enough cells or, viable cells within that specimen for them to actually get a good reading and a true report. So that can be really frustrating because when you, let's say 3 weeks later, get a report back and it just says QNS. That's all. Quantity is not sufficient. It's like, oh man, now I got to go back again. Do I rebiopsy, which is going to take another 3 weeks? So this can be really frustrating. Luckily, other tumor types are more cellular often than lung cancer. So you have a less chance of having a QNS rate, say for colorectal cancer. Usually you're getting better cellular specimens. So anyway, and then the last one I have listed here is another sort of form of a next-gen sequencing panel, but it's called an RNA fusion panel. This is the newest technique that we have. And again, most companies are now performing this. It's very, very sensitive for detecting our fusions. So for KRAS, you wouldn't need this because KRAS is a point mutation. So you're going to find that on the NGS panel. But if an NGS panel does not show any actionable mutations in lung cancer anyway, we will reflex that to an RNA fusion panel. And this is much more sensitive at detecting our fusion genes that are actionable, which is ALK, ROS1, RET, and it's actually MET and NTRK as well. And I'm going to show you one of my case studies where this kind of came into play. So again, it can also take a long time, but it's a more sensitive technique and something you may see on your reports if you're wondering what that was.
Let me ask you a real quick question on this slide though. Okay, will I know on my report, does it show which one of these I've had done?
It should. So when you have, and I'm going to show you like examples of these, but when you have your report, it should say what the technique was that was used.
Okay.
And
so
for example, like in an immunohistochemistry stain, that's usually going to be part of your original path report. Like it's not usually a separate report, whereas a next-gen sequencing panel is a completely separate report. Like this is a different company, a different assay. Immunohistochemistries are done virtually on all tumors because they're done at the time that the pathologist is reading them, because most of the time the pathologist, you know, I can't think of all the different stains that they use, but they have certain stains. Like they'll say, if I think this came out of the lung, I'm going to stain it for TTF1, for napsin, CK7. I'm trying to think of all the, you know, they'll say, well, if it came out of the GI tract, I'm going to stain it for this, this, and this, because that's going to direct them. Now, if they all stay negative, then they'll start doing other stains to see. The good thing about immunohistochemistry doesn't use up a lot of tissue, so they can keep staining to their heart's delight and they're not like really wasting tissue. Whereas with next-gen sequencing, it requires a lot of tissue and a lot of cells. And once we make that run, we've used up a chunk. So.
Okay, and you use the term point mutation. What does that mean?
Ooh, now you're getting, I'm a nurse. I'm not a molecular pathologist. But let me think about how to explain. Actually, I have a slide coming up, if you don't mind waiting just a second, because I have a slide coming up that talks a little bit about insertions and point mutations, because it gets a little tricky, but I think this upcoming slide will illustrate that better. Okay, I'm going to move on and talk about liquid biopsy, and then we'll get to some of those, you know, weird insertions, deletions, etc. So what is a liquid biopsy? So if you've ever heard this term, this is a blood test. The end goal is the same as the next generation sequencing testing like we just saw, except that it's coming from your blood. Now you might say, well, I don't understand. How can someone draw blood out of my arm and get cancer cells? Well, you can. So if your cancer is shedding DNA into the bloodstream, there will be DNA that we can detect from the bloodstream. Take that DNA and look for the biomarkers just the same that we would if we were doing this with tissue. Now, the downside of this is, under limitations here, is that you're not always shedding DNA on that day at that exact time that the blood is drawn. So sometimes you may get a report back that says there are no actionable biomarkers. That's not always true, because if you weren't shedding DNA at that moment or time, then we may not have found it. But the good thing is, if they do find it, KRAS is easily found on a liquid biopsy, we would find it. It's there. They don't call them if they're not there. So if they say KRAS, it's there. They didn't make it up. But if they say there is no KRAS, that might not mean that there isn't. It just means that they didn't find it at the time that they drew the blood. And sometimes we can predict this a little bit. If I have a patient who has a very low burden of disease, like maybe only a very small tumor, or in lung cancer, sometimes people have pleuritic disease, which is just cells in the pleura. that's not a very high burden of disease. So they might not be shedding a lot of DNA. So if I get a negative liquid biopsy report on them, sometimes I kind of take it with a grain of salt and say, well, they didn't find anything, but I'm not sure they would have found anything. So, but anyway, and I have a liquid biopsy sample report that I'm going to show you. So I'll show you what that looks like. And it should look pretty similar because they're testing for the same things. The one thing that liquid biopsies don't test for is PD-L1. It's just something that they don't have the ability to do as a stain right now because they don't actually have the tissue. That may change in the future, but for right now, that's the one thing. And they can't call histology. And I bring that up because, you know, if you have lung cancer or colorectal cancer, we will call that something like adenocarcinoma or squamous cell carcinoma. This cannot tell a histology subtype. It can only look for the biomarkers. So any questions about blood tests? The nice thing, obviously, about this is it's super easy. You know, while the needle's in, they're drawing your other labs, just pop these 2 tubes on and send them off to the company. Again, multiple companies around our country that does this. They want, like I always tell my colleagues, they want your business. So they'll send you the kits with the free FedEx envelopes. This can be done at home. We have had patients of ours maybe that live out of state. Before they even come see us, we'll get a mobile phlebotomy team out and they will actually draw some of these at home because the companies, you know, they want your business. So they'll make this easy for both us as the provider and you as the patient.
Okay, so to summarize, if it shows up as positive that you have it in a liquid biopsy, that means you definitely have it. However, by showing that it's not there doesn't mean it doesn't exist. It means it wasn't in that example of the biopsy, right?
Right.
And then the other part of that was, what was it you said? You didn't have enough tumor in order to test.
Right. So some people, if you have a low burden of disease, like your cancer is just not very big,
Right.
or it didn't spread to very many places, which is a good thing.
Mm-hmm.
But if you just don't have a lot of tumor in your body, you're probably not shedding DNA into the bloodstream at a very high rate. And therefore, that blood test might miss. Like I stood over patients getting this blood test done, and I told the phlebotomist, fill the darn tube to the top, get as much blood out of there as you can, because I want to capture DNA if it's there. Patients who have, you know, a lot of metastases or something, we should be able to get it. Like there should be a lot of DNA circulating, but there just always isn't a lot of circulating DNA, depending.
Or it just could be like what I've seen in that we saw that with the genetics and genomics with the pathologist, as far as like when the tumor sheds. That's
Exactly.
You know,
yeah,
it
we
just
can't always
doesn't mean it's
predict
shedding that moment in time, and you know you happen to catch it. It's just that part of it as well. And just because you would get a biopsy, pathology of your actual tumor tissue doesn't mean that they got all the cancer cells, like you were saying, to be definitive as far as what you have. Doesn't mean you have a bad doctor. It just means, you know, it's a teeny tiny little needle.
Right.
We've used the example of it's like trying to stick a teeny tiny needle inside of a blueberry muffin. You might get 100% blueberry. You might get 0 blueberry. You might be able to tell there's blueberry, but not know how much blueberry. And so there's that. Okay.
Yeah. I mean, we see less false negatives on tumor tissue. Usually we get a pretty high, you know, concordance right there. But we see more false negatives with the blood test than we do. So it's still the gold standard is to test the tissue. But another place this comes in really handy is, again, if you get that darn QNS, the bane of my existence. So your test results comes back and says, quantity wasn't sufficient. What do we do now? Pop these blood tubes out and send them. If they're positive, they're positive. You got your answer. Now, if they're negative, then honestly, the right answer is to try to go back and get more tissue to get your biomarker testing.
Right. So the QNS is just a matter of, we don't really know. We got a part of a muffin, but we didn't get enough to know what kind of muffin it is.
Right. We got muffin, but we don't know if it's cranberry or blueberry. And I can't tell that because you didn't get me enough of a bite of a muffin. Take a bigger bite next time. You know, I don't know. So, all right. Good analogy. So what are we testing for? So this, again, sorry for the lung centric here, but I wanted to give you just some examples. So in lung cancer, these bullets on the left are all the actionable mutations. But when you do a lung cancer panel on a biomarker test, there's going to be over 200 genes tested for. So this is just a sampling of some that are actionable that we have drugs to target. But I'm going to show you some case studies because there is a lot of reason to test for a lot more things because things keep coming down the pike. So that's why, and here's an argument that I just want to bring up. Some people will say, well, why would you test for 200 when you only need 9? And the answer, and so part of this is, I know it sounds crazy, but to do one run of a DNA sequencing panel and test for 200 genes takes less tissue than it would take to run just 5 of these 9 if you ran them separately. So it is actually cost effective to test for more, and it conserves tissue to test for them all at once rather than just these 9. So that is an argument sometimes that people will make. Well, why did I need to test for all these? And, you know, we find so many other things outside of just these 9 actionable mutations, not just in lung cancer, but in especially colorectal cancers. There are a lot of germline mutations that we find. I just found one this week in a patient of mine with lung cancer, which is fairly uncommon. That's more of a breast cancer, ovarian, colorectal cancer thing. But we find them sometimes. And had we not done that full panel, we would not have known about that germline test. And when I went back and talked to my patient, he said, yeah, my daughter's had breast cancer. My mother died of breast cancer. My brother died of pancreatic cancer. It was like every person. I'm like, oh my gosh, you guys really. So then we send them on for genetic counseling for their family to be tested.
So in your reports, do you get germline and somatic testing both?
Yeah, because that's part of the full NGS panel.
Okay.
So there will be germline tests, whether I want them or not. And then the molecular pathologist has to call me because I don't know. You know, I know these 9 that I'm looking for, and I know of smattering of others that I'm sort of looking for, but I don't know the ones that are germline. We rely on the molecular pathologist to tell us and say, hey, Beth, just so you know, this ATM, blah, 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 what is probably a germline, and this patient should really consider getting their family tree looked at and genetic testing.
Yeah, and actually ATM is something that I have. And we can't, I know that there's enough to know that there's some sort of tendencies, but they don't know enough about it, right?
Yeah.
And so, and rather than getting too derailed, I want us to get back to the biomarkers because I could totally go down rabbit hole.
Yeah, and, yeah, ATM's pretty common. So there's a lot of different ones. But yeah, and that gets over my head again, molecular pathology. All right, so let's specify more with KRAS. So again, I'm sorry again for the lung cancer specificity here, but
I'm Terri Conneran. Whoops. I don't know.
So that's what I do specifically. But this is just to give you an example in lung cancer of sort of what we're looking at. So KRAS is the most common biomarker we find in non-small cell lung cancer. It is the most common. Out of all of the KRASs, here is the breakdown of the different subtype of the variants. So KRAS G12C is the most common one that we find, which, as you may know, are actionable. The 2 drugs, sotorasib and adagrasib, are listed down here at the bottom. So these are both pills that target the KRAS G12C. They don't target the other ones, and you can see that especially G12V and G12D are also pretty common. We see a lot of those. And then we see a fair amount of G13s as well. So there's a lot of other KRAS categories that there are clinical trials for and drugs that are starting to look at trying to target these. But KRAS is the most common. And, you know, it's very interesting because KRAS was the first one we knew about. You know, when I started doing lung cancer 20 years ago, we knew KRAS. We had figured out how to find it, how to detect it. But it really took 18 years later until we actually were able to figure out a drug to target it. So it's an exciting day, really, for us to be able to figure this out because we've known about KRAS for a long time. And it's prevalent in several other cancers, obviously, outside of lung cancer.
Yeah, top 3. Pancreatic, colorectal, lung.
And lung, yeah. Okay, so this is going to get to your question about point mutations. So here's where it gets a little bit hairy. with over my head information that I'm trying to, and some of these I'm going to give credit to Dr. Jennifer Morissette. She is one of the molecular pathologists at the University of Penn. We did a joint presentation at one of my conferences, one of my nursing conferences, and some of these are her slides that she shared with me. But these, so again, when you're looking at your report, and I'm going to get to these reports in a minute, but when you're looking, these are some of the nomenclature that you're going to see. So something called a single nucleotide variant, which is what KRAS is. So what KRAS, so G12C in particular, so the G is glycine and the C is cysteine. So what this means is that at the G, at the glycine, at the 12th codon, there is a substitution for C instead, which is the cysteine. So this is a change of one nucleotide into another. That is called a single or a base pair substitution or a point mutation. Another thing that you will often see is INS or DEL. These are insertions or deletions. So for example, the second most common type of variant that we see in lung cancer is EGFR mutations. And these are generally deletions. Well, they can be any, actually. They have L858R as a point mutation. Deletion 19 is a deletion. And there's an exon 20 insertion. So there's actually 3 different types of EGFR mutations. And this all gets to those amino acids in that DNA helix. So if you think from my first slide, if you guys could see the DNA helix, but there are different codons and different amino acids there. And these are just either insertions of a like in the first one, where it's not supposed to be, a deletion in one of those DNA strands or one of those amino acids. Again, in EGFR, it's common at exon 19. So these are things that you may see, or there may be an insertion of an extra one that shouldn't be there. That often happens in exon 20 with EGFR. So you may see, you'll see on my next slide, but it may say INS, blah, blah, blah. That means it's an insertion. A DEL 19, you can see here, this says 750 DEL, that's a deletion. Copy number gain is another just mutation type. We know a little bit less about this as far as treatment. I'm sure molecular pathologists could talk a long time about copy number gains. We know less about this as far as a treatment strategy. We see copy number gain in EGFR. We see it in MET a lot, but so far that has not translated for us into our targeted therapies and efficacy. So it's not something that guides our therapy right now, but it's something that you may see on your report, just to be aware of it. And then the last one is translocations or rearrangements or fusions, I should put here as well. So these are where genes are fused together when they're not supposed to be, or they're rearranged, like they're supposed to be like this and they're like this. One of the most common ones for us is EML4 and ALK. So in lung cancer, if you hear someone say they have an ALK mutation, most of the time that is a rearrangement with EML4. So again, you may see this in your report, NTRK, which is a really, really uncommon, but can be in any tumor type. And there are drugs that are approved for NTRK fusions if you see it. This is another one that you would find here. So ROS1 is a fusion or a rearrangement. ALK is a rearrangement. NTRK is a rearrangement. RET is a rearrangement or a fusion.
So what is a skipping mutation, like in MET exon 14?
So interestingly, that can be considered a point mutation or a rearrangement. So I've had this conversation because originally, most of the time we were finding MET exon 14 only in our NGS panels. So my understanding was that this was a point mutation, but I'm also told that you can find MET exon 14 skipping under rearrangements, which is odd because you don't find EGFR, KRAS, BRAF, which are other either points or insertions. So those we don't find under there. So MET exon 14 is a little bit, I'm not 100% on that one. But I know that we do see it in our RNA fusion panels.
Okay. So all right. So okay, you're going to go through.
Well, yeah, my take-home point here is that these may differ. And so we talked about the technique, which was the immunohistochemistry FISH, RNA DNA fusion panels. This now goes one step further into that group of numbers and letters you may be looking at on the report to kind of determine what type of mutation. And again, this is all for your knowledge, because it's not going to matter necessarily whether you have a fusion or a point mutation or an insertion. The drug that's targeted is going to work for that if that's what that is. The one thing that you have to be, that can be confusing, for example, let's take MET, for example. So you may see on a report a MET copy number gain. You say, oh, I must have a MET mutation, or it's not the same. So you would want, because a copy number gain is not the same as an actual MET for exon 14 skipping mutation, which is the only one actionable. So this gets very, very confusing, even for providers, not for beyond patients, even for us as providers. So I'm always telling my colleagues, if you are confused, call the molecular pathologist. For example, I had an RNA fusion panel that came back and it said there was an EGFR mutation. Those were the words. So I thought, oh, great. This patient must have an EGFR mutation. I'm going to use EGFR directed therapy. But I called them because I said, I've never seen this on an RNA fusion panel before. And he said, no, that's not what you're thinking of. That's not an EGFR exon 20 insertion or an EGFR deletion 19 or an EGFR L858R point mutation. Those are the actionable ones. He said, this is a different EGFR that we call as some sort of translocation, but it is not actually the mutation that you're thinking of on an RNA panel. So I want to be clear, even me who does this every day, I can get confused on these reports. So I will always call. I know the names and phone numbers of our molecular pathologists at Penn in order to call them and talk with them about it, because I don't even always understand it myself.
Well, and that's a good, a good point to make, right? If you're an oncologist, if you're a nurse, okay, if you're looking at these reports, you're not a pathologist, okay? And so it's the pathologist or whoever it is that ran the test that have that information, that are the go-to source for that.
Well, and you as a patient can do the same thing.
Right.
If you have a question, believe me, these molecular pathologists love to talk about this stuff. They love it. So if you want to,
we may even have one or two on the call, and we had 2 hours with Dr. Eric Connick from Fred Hutch. And we went through the genetics and genomics of it, and he did an excellent job explaining, like, down and drilling into the detail. But it's good to hear from your point of view, because you're seeing it and you don't.
Yeah, it's not even always something I know. It's just like a CAT scan of the chest. I can read it pretty well, but I'm not a radiologist. If I have a question, I have to call because I don't know exactly, what I'm looking at, and this stuff gets really confusing. All right, and I want to get to my sample reports, and I'm really talking a lot here, my goodness. So don't want to spend tons of time on this, but this is what I was talking about here. This is all the numbers, letters that can be confusing, and that's why I wanted to explain to you. If you look, can you see my arrow when I'm doing this? I don't know if you can, but if you look at EGFR in the second line, the nucleotide variant, oh my gosh, I don't know all of those, glycines and cysteines and amino acids in there. That's way past me. I go to the variant on the left, but look what I see. I see del and insertion. So now I'm starting to understand a little bit. Okay, but I still don't know what L747 means. Now, if that said L858R, I happen to know that's an insertion, but a point mutation, but not everybody knows that. So these are just the different things you may see if somebody puts a report out. You don't have to know, you don't have to understand it. Now, separately, if this is going to be a translocation or rearrangement, it's going to look differently. Over here, you're going to see a certain chromosome. That's the genomic location. And then you're going to see if there's some kind of rearrangement. Again, I don't want to spend a ton of time on this, but this is what they look like. And this is why it can be so incredibly confusing when you're trying to read it. Okay, good. Let's get to my reports. All right. So here is a sample report. Now, remember how you asked me how will I know what kind of technique was used? Look at the upper left-hand corner. It's a solid tumor next generation sequencing. So I know this is an NGS report. Okay, so the tissue source here is pleural fluid. So I can see my disease associated variants. Are there any sleuths out there that know what on here is the actionable mutation that this patient has.
Yeah, it would be the BRAF.
Right, so this is the BRAF V600E, and it has to be the V600E. That's the only one that the actionable drugs we have for BRAF right now target. So that's that very specific point mutation that is in BRAF, and that's what was targetable on this report. Note the other one. I don't know what SCETDT is, but I happen to know, because this is my field, that that's not something actionable, but it was a disease-associated variant. This is still the same report. So when they report disease-associated variants, they're going to say, okay, this was associated with this cancer. We can tell you that. Variants of uncertain significance, they will say, okay, we also found this. We don't know what they mean, but we found them. So sometimes I don't pay as much of attention, but there's a lot of stuff listed here. Here you can see that ATM. ATM comes up all the time. It's a common one that we find, but we don't know what and that's the molecular pathologist telling you, I don't know what these variants are, but we found them and we're reporting them. So a lot of times you will see that. Okay, here is another patient of mine who's a 48-year-old male with hemoptysis, so was coughing up some blood, a large cavitary chest mass, and a routine MRI of the brain showed that he had brain metastases. So this is a liquid biopsy report because we wanted to get something back really quick here. And at my institution, they were telling us at least 3 to 4 weeks until we got something. And I'm like, ugh. So we sent off this liquid biopsy report. Now, this is a certain company that does liquid biopsies, which is fine. Can anyone tell what the what the actionable mutation is here? So this one is, so first they're saying, so ERB-B2, so the ERB-B is part of the HER family of receptors. There's exon 20 insertion. If you see in parentheses afterwards, that's them telling me, hey, Beth, I found a G776 del end insertion, so deletion insertion VC. Well, I don't know what that means. But what they're then telling me over here is that this is an exon 20 insertion mutation in the ERB-B or HER2, because HER2 is the same as ERB-B. So this is a HER2 mutation found at exon 20. At the time, like right now, as you and I sit here and speak, this is an actionable mutation. In lung cancer, we have a drug approved for this. In gastric cancer, there is a drug approved for this mutation. Now, if you though look, because this was done May 1st of 2021, so this was 2 years ago almost, there was not a drug approved for this at the time. So this company goes as far as to say, well, there's some associated FDA approved therapies, but they're not approved. So these are associated therapies, and then it goes on to list a whole bunch of things, but these are not technically approved. And then they say, oh, but there are clinical trials available. And then this company on page 3, which I'm not going to go to, but page 3 will tell you the clinical trials. So this is some of the benefit of using some of these companies, because they will not only tell you what you have, but if there is other things that are available for you, like a clinical trial. And then you also...
Would that be an exhaustive list of clinical trials you're eligible for, or does it mean that you're eligible? Is it just kind of?
It doesn't mean you're eligible, because eligibility criteria has a lot of things associated with it, but it would say these are available clinical trials for the HER2 exon 20 insertion. If you want to look into them on like clinicaltrials.gov, you can. So TP53 is also on here. TP53 is a tumor suppressor gene. It is one of the most common things that we find on biomarker reports. A lot of people will have TP53 mutations. Another one that falls in this category is P10. So these are tumor suppressor genes that when they're mutated, don't do a good job of suppressing tumors in the body. They're not actionable, but they're just telling us that this is another variant that we found. And then this company also at the bottom will tell you, we tested for 74 genes, and at minimum, these were tested for, because at the time, these are the ones that were, appropriate for lung cancer in this patient. So this is the same patient. So now we finally got back his actual next generation sequencing report. And as you can see here, again, it says NGS report in that top left corner. You can see that it does show his disease-associated variants are the same as what we found on blood. There is that ERB2, and they put exon 20 at the top of it there. Just, it's like, let me help out the lay people. This is an exon 20 insertion for her too. And they've also found the TP53. Now you can see that the VUSs, this is the same report. There's your variants of uncertain significance. Whew, a whole bunch of stuff listed there. Nothing that I know what to do with. Note ALK is over there. So ALK is like a buzzword in lung cancer, but ALK is a gene rearrangement. And this is some kind of gene protein change that was a VUS. If it was a true ALK mutation, they would have put it under disease-associated variants. So because it's under the VUS, it's not an ALK mutation or true ALK fusion.
Okay, because if it was a fusion, it wouldn't have the P after it. Is that correct?
Correct. It would have some chromosomal numbers. And they should have put it over in the disease-associated variants because that would have an effect on the disease. That would be your driver. Okay. So this patient highlights the point, this mutation was not actionable at that time, but it is now. So it could be in the future. And this patient, was eligible for clinical trials. This is another patient of mine, and bear with me on this because we tested him 6 times. So why did I test him 6 times? Well, initially he only had a pleural effusion that showed his lung cancer. So we're like, okay, so what did I get here? I see NTRK and RET. I'm like, oh, okay, but they're VUSs. They're variants of uncertain significance. I don't know what, they're not fusions. They're not the real thing. I had to call to make sure, and say, okay, these are protein. Yep. Nope. Not a fusion, not a rearrangement. So, okay. So we move on. And I get another one. So what's the date here? This was, we're still in August 17th here. So this is still the same one. Here were some of their interpretations and comments if you want to read in the report. Again, I want to get to some other stuff. So, but you can always kind of read about them. Again, a lot of this is over the head, so don't think like you have to understand this. But I want to just give the idea here. So we retested him again. So then he developed a pericardial effusion. So now this is 2.5 years later. This is November of 2020, same patient, still adenocarcinoma. You still see the exact same thing 2 years later. We're just calling these VUSs, the NTRK, the RET. I don't even know what TET2 is. So we're like, oh, man, okay, we tested again. But what the difference was in 2020, we now had RNA fusion technology. So here's his RNA fusion transcript. And lo and behold, this shows his EML4 and ALK gene rearrangement. And this is what I circled it there. So this was a game changer because we didn't know this before when we did not have that RNA fusion technology. So it was not a sensitive enough test to find this EML4 and ALK gene rearrangement. But once we were able to develop the fusion transcript technology, this is when we were able to find this. And I can report to you, this patient is now on ALK therapy and doing very well. We are 3 years later now.
That's always good to hear.
Yeah.
Now we had a question posted about the tumor burden. Does that show up on the report, and does that have a relevance?
That's actually a really good question. And no, it doesn't. And that's the frustrating thing with the liquid biopsy. You don't know if they just didn't find it or if there wasn't any DNA. They can't tell you that. I don't know why, don't ask me why, but they can't. So it's not, unlike the tissue report, they will say, nope, not enough here, I can't read it, you got to try again. The blood test can't tell you that. So you're kind of left guessing, like, is it actually negative? By the way, we tested his blood 3 times and all 3 times did not show up any mutations. But again, he had low disease burden with the pleural effusion and things like that. So
you just didn't catch it.
We just weren't catching.
Yeah. So, okay. So the high tumor burden, okay. Yes. That's not necessarily an actionable thing. What does that mean to me as a patient?
If there's a high tumor burden, it just means you're more likely to find DNA shedding on the blood test. You're more likely to find a biomarker if you have it. But it's not a slam dunk either. That just doesn't mean that the day they drew your blood that you were actually shedding DNA for that.
I mean, it doesn't necessarily mean that I'm going to have a higher chance
mutation, no.
of recurrence or
No,
anything.
no,
It's just,
no.
it's kind of just like something they keep track of.
It's just, yeah, the high tumor burden, and this is not tumor mutational burden. I want to make sure we're.
Okay, well, we'll cover both if you would.
Yeah, so tumor mutational burden is something that we test for on these next gen sequencing reports. And that just means like, how many different mutations do you have? Is there a lot of them? And right now we don't really know what to do with that data. We used to think that, or we still sort of think that a high tumor mutational burden will make you more likely to respond to immunotherapy, but that data has been up and down. So that sort of is still out there. Tumor burden, not tumor mutational burden, tumor burden, that just means what I'm seeing on your CAT scan. Like, is there a 6 centimeter mass as opposed to a 0.5 centimeter mass? If there's a larger mass or there's more tumors there, then you're more likely for me to be able to find a mutation if you have it. It doesn't mean you're more likely to have a mutation. It just gives me a better chance at finding it.
Okay, so it's a bigger target for you to hit with the needle to take a pathology.
And I'm more likely that it's shedding DNA for a blood test.
Okay. And
Yeah.
so, so tumor burden is different than tumor mutational burden.
Right. I don't want to, yeah. Tumor mutational burden is an actual test that they can, there's an equation to it that I don't really want to get into that's very complicated, but there's an equation to it. And it sort of just means how many different mutations or what is the makeup of your tumor that looks at a lot of different mutations. And we used to think that that meant that you would respond better to immunotherapy. And I think there still is good data to say that you would, but there's some data now just that is discrepant to that. So. Okay, so this one I wanted to make the point that, keep testing. You may not have found it for several reasons on the first go rounds. In this patient, we suspected something was going on based on some of his clinical characteristics, especially his young age. So we just kept testing. I wanted to give you a patient with KRAS G12C. Not much else in this, just to keep showing you reports. This patient oddly had 2 different actionable mutations. And at the time, if you look at the date of this report, 12/12/2018, this patient did not have any KRAS options at the time. There were no drugs approved. So we actually ended up treating the BRAF first, and then a disease progression. Well, actually, I'm going to show you this, so I'm giving away the news. But anyway, so he had 2 actionable mutations. Long list there of VUSs, long list. Nothing that I really knew what to do with. There was a BRCA2 there, which is a breast cancer one, but not one that we were told was a germline.
Okay, so since that's up there and everybody's heard about BRCA, even though it's a really small percentage of people, right, that it affects. Okay, so when you see that on the report, it doesn't necessarily mean it's the BRCA.
That's correct.
Because it may not have the same insertion, deletion, mutational change that makes it important.
That makes it important or considered to be a familial or germline mutation, correct? So his was not. But sometimes I like to just show that just because we see this, and that's why it can be confusing.
Well, and that's important because that's what we're looking at, and we're seeing all this stuff, and it's like, where does this fall, right? Yeah, and then you start Googling things, and then there you go.
Right. So then this patient, he got the BRAF directed therapy because there was nothing for KRAS at the time. When he progressed, he went on a clinical trial. And then in June of 2021, he did end up going on a KRAS medication. But I wanted to note here, if you look at the timing here, so his report date now, December of 2020. So this is, let me go back. What was the date? So this is 2 years later. We tested his blood because he was progressing. We like to test the blood test, that progression. And note, he lost the BRAF. So, and this happens sometimes. So we treated him with the BRAF directed therapy, and he lost then that mutation, probably because his cancer smartly figured out its way around it. I don't know, but we treated that mechanism. It lost that mutation, which we see this a lot with EGFR actually, where they lose their EGFR mutation after treatment and gain a new one. For this patient, he lost his BRAF, but has still his KRAS G12C, which makes sense because we didn't, at the time, we had not treated him for that pathway. Now you can see at the time, none of the KRAS drugs were approved yet. So it says again on this liquid biopsy report, well, there's this therapy that could be associated, but it's not approved. And then there's clinical trials. But then once the drug did become approved in June, we were able to treat this patient with it. So just an interesting point here that, you can still harbor the old mutation and you may lose a different mutation at the time of progression that you had already had treatment for. So
do you lose it or does it change?
You lose it. So you lose it usually, or you develop a resistance mutation. So this mostly happens with EGFR. So in EGFR mutations, we'll treat with an EGFR directed therapy. At the time of progression, we will retest with the blood and we will see that the EGFR mutation is no longer there and a new one has occurred, such as a MET amplification or a C797S is another resistance mutation. HER2 is a resistance mutation for EGFR. I'm trying to think of all of them. There's a bunch that we can find, and then we can figure out clinical trials or targeted therapies for that specific acquired resistance. T790M.
We've seen some ALK fusions that have morphed into KRAS mutations, and sometimes KRAS mutations can morph into an ALK fusion as well. And just as for people that are in the call, there is a G12C. If you are on any sort of an inhibitor and it has changed for free, they'll do a liquid biopsy, and it's through the SPARK protocol that they're doing at Dana-Farber. And they'll take your blood so we can kind of start tracking this.
Yeah.
Anyway.
Yeah. So resistance testing is important. So I just wanted to end up with some barriers, and this is like a big slide, but this is, I'm showing you all these biomarker tests and reports and how to look at them and what you're looking for. But there's a lot of barriers to biomarker testing. You wouldn't believe what I hear some people say. Some people say, oh, I don't think I'll ever find a ROS1 because it's only 1%. Or I've never seen that drug work for anyone, so why am I testing for it? The tissue barrier we've talked about, there's not enough. Or you had it done in Florida, but I'm up here in Philadelphia, and the company in Florida won't send me your tissue so I can test it. They will eventually if you keep fighting them, but sometimes it takes a lot of fighting. Complex reports, that's what we just talked about. So hard to decipher reports. I mean, I'm talking to you as patients, but this is high level stuff. I mean, a lot of us as, nurse practitioners and physicians don't understand this all the time either. And we have to make phone calls. Just make the call. Just talk to the expert. The timing is annoying. We talked about that. The nice thing about the liquid biopsy is it only takes about 5 to 7 days. So we get those back really quickly. Now, again, they're not 100%, but, and then administratively, just trying to find the report. This may sound ridiculous, but honestly, are we still relying on fax machines? Sometimes, yes. So if you're a patient and your doctor's like, I haven't got my report, call the company. I would just be on the phone with the company myself and say, go get the report, because you have access to your own records, so you can get those reports. So if anyone's telling you they don't have the report, you're allowed to call whatever company they use and get the report.
And that's a good question. Mo asked, can we call the pathology department about our records?
Absolutely. You can call whoever you want. It's your records. At University of Penn now, we release everything immediately to patients through our portal, through the online portal. They used to put a delay on things like radiology reports, but they don't anymore. There's no delay. Patients get it immediately. I think that pathology might still have a 3-day delay, only so that we can explain it better for patients, but I'm not sure that it does. I think it might be immediate now. But yeah, you can call anytime and get your own information to whoever you want.
And a lot of it, if they're doing the reports at an offsite lab, okay, one of the big labs, Foundation, KRAS, Garden, whatever, they always have a phone number you can call. And they know their reports inside and out. And I've heard very good things. I haven't spoken obviously to all of them, but I've heard very good things about their explanations and what have you as well.
Plus they have patient portals too, just like University of Penn does. So all those companies, the big ones like you just named, they have patient portals. So you can be on your own portal and get your own results and communicate with them that way as well. So then this is just a list of different databases. I'm going to tell you my favorite one is at the bottom. So I use mycancergenome.org. I love it. You can literally put in that whole big list of like that BRCA2 P6598 and put the whole thing in, and it usually will be able to tell you, excuse me, what that is if it's actionable. So these are really pretty cool ones. I haven't really used the other ones as much, but we use my cancer genome a lot. And then I did have a resource. I don't know if you had it, Terri, or if you were able to post it, but that the looking at the biomarker report that I was part of with longevity. So did I?
Yeah, I don't remember off the top of my head. So yeah, I know we work in conjunction with longevity. We work with all the organizations as far as like we got like a no one needs campaign and stuff.
I can show it to you real quick if you want.
Yeah.
Wait, how the heck do I get out of here? End the show. Here, this is the one that I wanted to show you. So this is for reading your report. I don't know if you've been able to see this. It's just a small booklet that's available that Longevity put out. And this had patient and provider feedback, just helping you, again, understand what you're looking at. Oh, I can't scroll very quickly, unfortunately, but
yeah, I know.
There's some things like what we just talked about, like what the method was, what the biomarker is, the most common types. So that's a good resource as well.
Yeah, and we didn't kind of get into any of the other things as far as like co-mutations and that sort of stuff. Because what we're starting to see in like specifically is like the STK11 and the KEAP1, and there's a whole lot of stuff evolving around the co-mutations that would be on your report, but it's still very fresh, it's still very new, and it's not necessarily definitive as of right now. So, and with that, I can see it's 1 o'clock. Oh my gosh, I didn't think we were going to get through all those slides in an hour. You did a fantastic job, Beth. I appreciate that.
Yeah, thank you. A lot of really good questions.
Yeah, if anybody has like a quick question, post it in the chat. But otherwise, I just really want to thank you for going through what's, one of the most important things in our estimation, as far as getting the biomarker testing, taking a look at it and not being overwhelmed, and just hearing from a healthcare professional such as yourself that it's perfectly okay for us to call. And it's totally acceptable for a doctor to say, well, I'm not really sure about what that means. Okay. And it doesn't mean you've got a bad doctor if they were not able to get a result. It just means they stuck a bad part of the muffin. And I have plenty of muffin top to go around. So you'd be surprised if they didn't get enough of whatever it was that they needed or wherever the hell. So anyway, okay, but I digress. Okay, thank you. I see a lot of thank yous in there, and thank you so much for your time and your energy and your effort in putting everything in together. And I really appreciate you and everything that you're doing. And I hope that we can actually meet together in person again here in the very near future.
Yeah,
okay.
Well, I actually want to thank all of you. Like I've been doing, like I said, for 20 years, and patient advocacy is so much of what cancer care is. And it's awesome to have all you guys like being part of this organization, and Terri for founding this organization. This is incredible. And this is the way things get done. So I love hearing stuff like this. It makes me so excited that someone else cares as much as I do.
Totally. I mean, that's why it's BAM cancer, right? Okay. That's part of it. And we just need to know. And, I really do appreciate it. And that's all we've got to do. But thank you so much. And I hope to see you again soon. And next time you won't be all aglow quite. Okay. All right. With that, everybody, thank you so much for joining. And this is Terri with KRAS Kickers. Bye now.